I'm Tom McCoy, and I'm here to talk about the so what of SaAMS. At some level, I expect the title offends you, and that is the point. So I have many little hats that I wear, but one of them is that I'm the enterprise architect for medical devices at MGB. That means that when a motivated clinician, an expert at the bench and the bedside, brings forward a new technology that he or she wants to champion, I am the beating heart of bureaucracy that has to say yes. And when I think about saying yes, I don't think about me, I think about Bill. Let's do orders of magnitude. Bill's got about 10 million clinical square feet with about 100,000 devices in it and about 100 guys to care and feed them all. We have a support nightmare at the hospital. Even if I wanted to say yes to everyone, we couldn't afford it. And I don't want to say yes to everybody, because if I did, the system would collapse under its own weight. And so we're forced to pick and choose. And we're forced to pick and choose between systems that are wildly non-comparable. This isn't a down select where we write an RFP and we have 10 broadly speaking equivalent devices that show up and we pick the best one. We're talking about systems that have nothing to do with one another, but are competing for our scarce resources. I think SaAMS have a unique so what story, and I want to walk through that because I know you're going to succeed. I can't wait to see how successful you are. But when you get to the end of the road and it's time to get across the red line into the hospital, some fairly irritating bureaucrat is going to have to buy in and say, yeah, we want that here. And when I say yes to you, I accept that I'm saying no to 1,000 other people. And they're really smart, and they're really well-intended, and they're really motivated. And that's the price we're going to pay at the point of care when we say yes. So how do we compare between things that have no natural comparison? We have to look at the big picture. What are we trying to get to? We know healthcare in the United States is too expensive. I think we were back down to about 17% of GDP last year. No one wants that number to go up. Whether the comparisons to the rest of the world are fair or not is debated, but our number's mighty big, and it needs to head down. We've seen that we're too hard on our workforce. Workforce well-being got added to the triple aim in 2014, and people thought, it's a little squishy. Aren't we the sacrificial lambs? It'll be okay. COVID showed us that that's not true. You need 10, 15 years to make a critical care doctor, but you can burn one out in 8 weeks. You're never getting them back. You can't work with that. Then there's the foundation. We want to produce good healthcare. We want that healthcare to be a plausible experience, and we want it to be an equitable experience. This is the so what that we've got to shoot for. Now, you're all imagining that you're going to produce more efficacious devices, something that'll be micro-titrated with AI, and you will. It'll be spectacular. You're all imagining that you're going to build safer devices. We'll avoid those preventable medical errors. We've already seen the BMJ 2016 paper drive by. I will, of course, remind you all that there's very real contention about that estimate. Many credible people believe that it's an order of magnitude too high, but I don't think it matters. Whether 250,000 people a year die from preventable medical errors or 25,000 people a year die by preventable medical errors, isn't it too many? Wasn't the first one too many? So what else does SaAMS have to offer us? It's that what else that I'm going to talk about, because all of the other stuff is mom and apple pie. I want to talk about our workforce. This is the population pyramid of the United States today. A population pyramid is just 2 histograms turned on their side. Women are in red, men are in blue, babies are at the bottom, old people are at the top. Our pyramid looks plausible right now. You all could fill in the blanks before I hit the button. Back in '64, when the boomers were starting to come onto the bottom of the slide, we had a really stable pyramid. A lot of young people, not so many old people. When we look forward 60 years instead, our once stable pyramid is starting to look like a bit of a tippy tower. And for those of you who are clinicians, if you think about the last time you were doing inpatient rounds, you know what it looks like. You've got a lot of prime working age adults standing around the bed, and the oldest person in the room is the one in the bed. So broadly speaking, the patient comes from the top of the pyramid, the staff comes from the middle of the pyramid. That's a problem. If you divide the top of the pyramid, those older adults, which are disproportionately where our patients come from, by the middle of the pyramid, the working age adults who are disproportionately where our staff come from, you end up with an old age dependency ratio. For the entire 20th century, when we built the healthcare establishment that we all know and love, we had a old age dependency ratio of about 25%, less than 25%. By the time we get to 2075, it'll be 50%. Whether you call it twice as many patients or half as many providers, either way, the odds are not in our favor. Demography is going to move forward like a glacier down a mountain. It is coming. If you think we have a staffing problem today, the staffing problem is going to be worse tomorrow and the day after that. Now, I can hear you thinking, we'll import the labor. The US is an incredible place and people are desperate to come and work here. And that's true, but it's probably not going to solve this problem. Now I've added to the plot every single country for which the OECD has an old age dependency ratio estimate. Our problem is not just ours, it's the whole world. There isn't a massive reserve of highly skilled young people out there that we can import to meet this need in the United States. They're going to be busy meeting the need at home. Now, it gets worse, of course, when you squeeze those people through the professional training pipeline. Today, Health and Human Services estimates that we're short 300,000 nurses. We're short 2,000 anesthesiologists. I heard Julian rankling last night at the idea that he had another 20 years in him, and I want to be very clear, it's essential that he has another 20 years in him because we're going to be short 6,500 anesthesiologists in just 12 years' time. And you're all doing the math in your head. If you speed run it, 2 years of pre-med, 4 years of med school, residency, fellowship, the time to plant an anesthesiologist is 12 years ago. Registered nurses, anesthesiologists, I picked them because they felt most relevant, not because they're unique. This is what it looks like across the Health and Human Services forecasts for healthcare professionals. We're not going to have the people we need. And so if in the 2015 period when the self-driving car revolution was going to add to the economy of despair by putting 2 million professional men, mostly who professionally drive vehicles, out of work, that's not our problem. This isn't a question of whether we're going to put doctors and nurses out of work. This is a question of whether we're going to have enough doctors and nurses to meet an expanding demand that we know is coming. SaAMS, I think, can help fill this gap. Now, it's not a biomed conference unless somebody makes an incredibly elaborate analogy to aviation. And so I am here to help you all complete that box on your bingo card with this lengthy analogy to aviation. In '38, when the Boeing 314 took off and started the Clipper service, it did so with a minimum cockpit crew of 5. It was probably more like 11 on most regularly scheduled flights. By '57, when the 707 barrel rolled us into the jet age, it did so with a flight crew of 4, a navigator, engineer, 2 pilots. You can see the navigator there. He's got a periscopic sextant rammed through a little blowhole window. That sextant's enabling him to do celestial navigation that would have been familiar to sailors for thousands of years. In '63, when the 727 took flight, that's the one that D.B. Cooper went down the little flight of stairs on the back and jumped out of. The navigator was gone. You can buy that sextant on eBay for $1,000 now. I'm not quite committed enough to this deck to buy the sextant to bring with me, but I've thought about it. Now, in '67, we're not quite to the moon yet, but we're nearly there. You're down to the 2-man flight crew that's going to fly you home tonight in the 737. That's the sort of attention to staff resourcing that's going to be required to use the workforce we have to meet the healthcare demand that we know is coming. This is the attention to our staff's time that we need. This doesn't mean more efficacious medical devices. It doesn't mean safer medical devices. It means that administrative burden alone is a compelling so what, not in the century ahead, but in the decade ahead. This has got to be part of the so what story. Unfortunately, it's not a free lunch. The 737 story doesn't end in 1967. You've all seen the MCAS crashes. You know that Bolting software onto a legacy platform is financially responsible. You don't have to redo the whole platform. You're respectful of the effort to train the crew over again. Unfortunately, you discover new unknowns, points of failure that you didn't realize were essential points of failure. That'll probably happen to us. I know we'll live up to the task and we'll re-earn patient confidence when we put it at risk. And we're going to get there with the safer, more efficacious care that everybody needs. We'll bring in that IT risk that so many have spoken of. The hospital vulnerability assessment from 2020 listed IT as the biggest threat, pandemic as the second threat. I think that pandemic call puts their bona fides sort of front and center. They got that one right. I bet they're right about the IT too. And so as we think about the new opportunity that smarts bring to clinical equipment, and look back at the incredible contributions of PMP over the past 10 years here in mid-June, I can't help but think that this is a little bit like graduation. So Julian, thank you for 20 years of incredible work. Thank you to this entire community for 20 years of incredible work. I can't wait to see what comes next. I know that you know what Richard Feynman told us all in 1974. The first principle is that we must not fool ourselves. Unfortunately, we're also the easiest ones to fool. We're going to get there. It's essential that we do, and I know you guys are going to be the ones that do it. Thank you so much for the chance to be here today.